Good afternoon. My name is Roger Bishop. I'm going to build upon some of the discussion yesterday from Dr. Davis where we talked about gene assays, and I'm going to talk specifically about early breast cancer and the utilization of genomic assays for assessing risk of recurrence and stratifying those patients. Now, my role at Novartis is an Eastern Regional lead here where I work with healthcare systems and I lead a team that work with healthcare systems to ensure that the work that you're doing is being implemented in a standardized and structured fashion so that patients benefit from this work that you do on a daily basis. Now, when I talk about biomarker testing in early breast cancer, of course, historically, we've looked at this risk stratification through clinical pathological features. We've used the American Joint Committee on Cancer Staging System to look at the size of the tumor, the nodal involvement, and the metastatic status, and that's given us a prognostic risk score for these patients in terms of short and long-term risk. In today's environment with precision medicine, of course, many companies have brought to market, and some individual healthcare systems such as yourself are bringing to market, the ability to evaluate the risk genes that may contribute to that risk of recurrence, and through RNA expression and reverse transcriptase, then pull out of those genes the exact expression for that individual patient and for that individual tumor. Now, we do this, of course, because we're trying to identify who should be treated with adjuvant therapy and who could avoid the toxicities that are associated with adjuvant therapy. Now, when we look at other cancers, other malignancies, we look at the risk of recurrence, and the perception in the society is that breast cancer has less recurrence in that early stage patient population. Yet when you look at that breast cancer patient population, overall you can see that the recurrence rate is very similar to other malignancies. It's just that it's longer in many cases and the mortality is less with all the advances that we've made in this area in terms of screening and diagnosis at that early stage. And particularly if you look at the early breast cancer patient population with hormone-positive HER2-negative disease, and we stage these folks, we know from Pan et al. That published this work a few years ago that a third of these patients are going to recur if they have stage 2 disease, and half of these patients are going to recur if they have stage 3 disease within that time frame of 5 to 20 years, which is that long-term risk of recurrence. And this is regardless of their initial 5-year therapy with endocrine standard of care. Now, this is also regardless of their nodal status. You can see here in this similar work that the 3-year survival status, or not survival status, but the 3-year risk of recurrence is around 10%, whether you're a node-negative patient with early hormone-positive HER2-negative breast cancer, or you have 1 to 3 nodes involved. And when you look out 20 years for that longer risk of recurrence, we see that it jumps to 30%, even for that early breast cancer with no nodal involvement. And so our role at Novartis is to work with healthcare systems to ensure that we're not just looking at the clinical pathological features or the genomic assays, but that we're combining these features. We're looking at the clinical pathological features, we're looking at the genomic assays, the variety of them that are on the market and some that are being developed in-house, and we advocate for structured standardization by combining the both approaches to the risk of recurrence through online risk tools that are open source and available to anyone to utilize at no charge. Now, when we talk about, of course, the clinical pathological features, we're talking about these patient characteristics, these tumor characteristics, the diagnostic and screening. And when we talk about gene assays and looking at a risk of recurrence through gene expression, we're talking about those particular genes that would contribute to that risk of recurrence for that individual patient and that individual tumor. And of course, these commercially available products, they differ in the number of genes. As a matter of fact, if you take an African American and test them with one and then test them with the other, you'll get different risk scores. So there's a variety of these on the market. They also differ in the fact that they can be either prognostic, a high or low risk score, or they can be predictive. They can predict what adjuvant therapy will benefit and who it will benefit. Now, we do this obviously because we want to identify specifically who's going to benefit from chemotherapy and not give it and expose it to patients who aren't going to benefit but will experience the side effect profile. We also look to see who's going to benefit when they're hormone positive from an additional 5 years of endocrine therapy beyond that initial 5 years where the standard of care lies today. We also just provide further information beyond the clinical pathological features for our assessment of the risk, and we can get that distant recurrence risk stratification out 10 years. Here you see the NCCN guidelines. They clearly recommend that we should be using genomic assays for patients in early breast cancer for the consideration of adjuvant therapy. And that's both for nodal involved patients and patients that are N0 with no nodal involvement at initial therapy. These patients should be receiving these tests. And you can see the variety of tests there. And then when we look at those tests here, of course, we're all familiar with the biomarker testing for ER/PR hormone expression, so we can analyze whether we're not going to use endocrine therapy, the HER2 expression, so we can choose a monoclonal antibody and target that HER2 expression, or a germline BRCA1 and 2 mutation, where we can then make that patient eligible for poly-ADP ribose polymerase chain, poly-ADP ribose inhibition. On the prognostic side, we see a number of these tests out there that are prognostic, but they don't give us any predictive information around what should I do with that high or low risk score that I receive. There are tests out there that provide us both predictive and prognostic value. So they can provide us a high or low risk score as well as tell us who needs benefit, who will benefit from adjuvant therapy, chemotherapy, or who has a high or low risk score and who will benefit from that additional 5 years of endocrine therapy. And this is what we try to do to mitigate not just that 5-year short-term risk, but that out to 20-year risk where we talked about earlier, the chances may be up to 30%. Now, historically, we've seen these patients receiving endocrine therapy when they were low risk, but the data clearly demonstrates that those patients may recur even though they're getting that endocrine therapy. And patients with high risk, we've identified patients who may not benefit from high risk from chemotherapy, even though they are high risk. And there's a broad population of patients in the middle. And this patient population may have a clinically high risk, but a genomically low risk, or a genomically high risk and a clinically low risk. And so what do we do with those patients? And it makes it very difficult for not only the healthcare professional to determine how to proceed with therapeutic options, but to communicate that to the patient and how we are going to proceed with their therapeutic decision making. Here we see some of the work that we talked about yesterday in terms of disparities. Who's getting these tests out there? Who's receiving a gene expression profile per guideline recommendations? And you can see here the Black, Asian, and Hispanic women are being tested at a lower pace, as well as lymph node positive disease, which is just assumed is a high-risk patient. Patients with lower socioeconomic status, patients with larger tumors that live in rural areas, and patients of older age. All of these patients may be missing guideline concordant care, which you can see here where ASCO recommends that all premenopausal patients with hormone-positive HER2-negative disease, if they're node negative, receive a gene expression assay. And all postmenopausal women who have less than 4 lymph nodes involved should be receiving this test. Now, of course, there are barriers. We talked some about this yesterday. Some hospitals and healthcare systems don't have the multidisciplinary team and the molecular tumor board that advocate for a genomic assay and the concordance with the guideline recommendations. Insurance coverage is not always good, and we reach that point of financial toxicity where we see prohibitive out-of-pocket costs. We know when we look at the Medicaid patient population, they are less likely to receive one of these tests. Patients also may just refuse to take a test. They aren't going to take chemotherapy, so they don't need to know, or they're going to take some type of therapy and they want to start it today. They don't want any delay in terms of turnaround time for some genomic assay. And then finally, that provider-patient communication, where patients and physicians have to get on the same page with the understanding of the risk of recurrence in early breast cancer in order to enable shared decision-making, which is such an important component of this early-stage disease. Now, these tests have limitations. We talked about this yesterday. Black and Hispanic women, even though they may have similar risk scores to Caucasian women, they have poorer outcomes. Men may have identical risk scores to women, and then they end up dying sooner. So what we try to do at Novartis, and I think most of you remember me from last year, we are unrelated to our commercial team here in the Personalized and Precision Medicine group. So what we try to do is work with healthcare systems, standardize and structure an approach to risk recurrence stratification in early breast cancer patients by combining the clinical pathological features with the genomic assay risk scores through a standardized approach and an online risk tool that's open source and readily available. This work was done by Valerie Crowley at London College, and it clearly demonstrates here that if you take a genomic risk score and you give a patient a risk, and then you add on top of that the clinical pathological features and take a dual approach, you're going to reclassify half of those patients outside of a low risk. You're going to reclassify 20% of the patients with high risk out of that high risk. And this gives the clinician and the patient further information and opportunity to assess that shared decision making and how am I going to approach my risk of recurrence at this early stage. So I'm going to close here and indicate that our commitment is to combine this and advocate for this approach to risk of recurrence, utilizing the clinical pathological features, utilizing these risk tools that are available, knowing about their limitations and the disparities in their use, but through the combination, working to refine and getting a more comprehensive risk analysis for these patients who have early breast cancer that have many years of risk in that ongoing risk of recurrence. Of course, ASCO recommends that we combine these risk assays with these clinical pathological features, and we think that establishing this as an approach to risk of recurrence gives us a better, more personalized and individualized picture of the patient's risk, their comfort with that risk, and our ability to communicate with them around shared decision making. We have resources at Novartis that we provide to healthcare professionals to help them in their ability to standardize the approach to risk of recurrence. We also have patient resources that we've developed through patient advocates and breast cancer patients to help them understand the value and the benefit of having this risk stratification in the most comprehensive way, so they can make the decisions about how they're going to proceed for the next 20 years with their risk of recurrence. Again, my name is Roger Bishop. I am the Eastern Regional Lead here at Personalized and Precision Medicine for Novartis Oncology. Can't thank you enough for having me again this year. Really enjoy this conference, and have a great meeting. If you want to chat, I'll be around the rest of the meeting. Thank you very much.